Dear colleagues, welcome to today's European Heart Rhythm Association webinar on anticoagulation issues in the elderly and patients with chronic kidney disease and atrial fibrillation. I'm Professor John Cam from St George's University of London in the United Kingdom. Please take a moment to look at my disclosures. I have the pleasure today of being joined by Professor Collins from Tallaght University Hospital in Dublin. Welcome, Ronan.
Thank you, John.
And also by Martin Hemmels from Rijnstadt Hospital in the Netherlands. And welcome to you also, Martin.
Thank you, John.
The aim of this webinar is to give you a better understanding of the oral anticoagulation management of elderly patients with atrial fibrillation, comorbidities, and polypharmacy through clinical case presentations. This session is interactive, and we strongly encourage you to actively participate by sending your questions and comments at any time during the webinar through the chat. For the best learning experience, we also invite you to participate in online assessment sessions in the form of MCQs that will be submitted during the presentations. This program is supported by the Bristol Myers Squibb and Pfizer Alliance in the form of an educational grant. Now I'm going to hand over to Professor Collins for the first presentation. Ronan, over to you.
Thank you very much, John, and good evening, everybody. My name is Ronan Collins. I'm from Dublin in Ireland. I'm a geriatrician with a specific interest in stroke medicine, so it probably comes as no surprise I therefore have a specific interest in atrial fibrillation. And I've been tasked with talking about anticoagulation considerations in older people. You will note I say formerly known as the elderly. Us geriatricians like to refer to people as getting older, maybe, rather than just being a group. These are my disclosures. And I thought I would start by reverting this on its head to some extent and talking about a youngish 92-year-old woman who presented to her emergency department only a couple of weeks ago with a pretty significant stroke syndrome, recognizable to most stroke physicians as a total anterior circulation syndrome. You see the National Institute of Health stroke score of 25, which is a pretty severe stroke. You can also see that prior to the stroke, even though she was 92, she was living at home reasonably independently with a modified Rankin scale of 1. We'll have a look at that shortly. In her past history, however, this woman had atrial fibrillation for a number of years. She had a history of hypertension. She had a fall with a fractured hip approximately 5 years prior to this, and post-operatively had a small intracerebral hemorrhage. There was a question mark as to whether it was due to low molecular weight heparin at the time for DVT prophylaxis, but she made a very good post-operative recovery and went back home with a modified Rankin scale of 1, as I said. But currently, as it stands, she would have had a CHADS-2 VAS score of 6 and a HAS-BLED score of 3, even though it was never really validated in a population quite this old. I thought this slide is a little bit busy, but the points I wanted to make is that polypharmacy is very frequent in older patients, and this lady was on aspirin rather than an anticoagulant. And also in terms of geriatric medicine, importantly, the functionality of the social history, living at home, walking independently, using the stairs, only stopped driving a year ago, and did have a cognitive assessment 5 years previous, which was relatively normal. You will also note the importance of collateral history when it comes to assessing function, and apart from some slight memory loss, this lady was independent in all PADLs but had 1 hour of home help a day. So in gerontological speak, when we talk about functionality and we talk about the modified Rankin scale, this lady would have had a score of 2, a slight disability. She had given up some tasks like driving, she had a bit of home help, but by and large looking after all affairs would be roughly considered independent in terms of a stroke outcome from her previous intracerebral hemorrhage. Now, she initially, of course, had a CT scan, and the initial CT scan on the left, as you can see, looks relatively normal, apart from some age-related atrophy. We now use some decision-supported software to detect early ischemia, which was evident clinically anyway. You can see the threatened ischemia in the caudate and maybe a little bit peripherally as well, giving us an aspect score of 9 by the software. I thought it was 8, John. But more importantly, if you look at the CT angiogram, this brings home the significance of atrial fibrillation in older patients, really. You can see that middle cerebral artery comes to an abrupt occlusion due to a large thrombus blocking. You can see very poor flow distal to that on the left side of the brain, where the arrow is in the second picture compared to the other side. And then in the delayed phase of the angiogram, you see good collateralization, which is very important in keeping the brain viable, where arteries from the surface penetrate deeply and, if you like, provide a collateral circulation to the threatened area of brain. So again, some decision-supported software can actually analyze and show you where the occlusion is occurring in the distal middle cerebral artery. So this lady was treated as like any stroke would be fast positive. A door to decision time of about 19 minutes, and we decided not to thrombolize here because she previously did have an intracerebral hemorrhage, but she was sent pretty quickly for thrombectomy. You can see the instant effect of thrombectomy here. The NIHSS score is only 7 the next day. She's talking now, she's moving the right side. And we treat her initially with high-dose aspirin because she's had a stroke. And on the blood workup, I suppose most importantly to focus on the renal function here. This lady has an eGFR of 38 mils per minute when calculated out. And I suppose the question to the audience, bearing in mind that although this lady was 92, she presents with a very significant stroke, and we did know she had atrial fibrillation at the time of the hip fracture and the intracerebral hemorrhage. So was the initial decision of lifelong treatment with aspirin monotherapy at that time the correct decision? Was nothing initially maybe, and a review regarding anticoagulation 1 to 3 months after the intracerebral hemorrhage a better decision? Should there have been aspirin initially and then a review regarding anticoagulation 1 to 3 months after? Should we have thought, well, listen, either way antiplatelet or anticoagulant would be a big risk here and probably outweigh the benefit? Or no antiplatelet or anticoagulant again because the risk outweighs the benefit, but consider an atrial appendage occluder? So that's the first question I would pose maybe to listeners to maybe consider and see what they think.
So think about these 5 possibilities. It presents to you the big problem of how you approach anticoagulation in the elderly patient. So give it some thought and vote now, please. So the voting is going very well, and it's clear that the majority of people favour option 2 or option 3. What do you think about that?
Yeah, I think that I would have favoured option 2 myself if we're strictly talking about stroke prevention. Of course, some orthopaedic surgeons do like to use aspirin from a point of view of DVT prevention, post-hip fracture. Of course, there is some evidence for that as well. But I think option 2 was probably the one I would have gone with. And I suppose initially, if we just deal with that question of risk of bleeding briefly in intracerebral hemorrhage and how it affects our decision-making with anticoagulation, I suppose the first thing to say is we now have a deeper understanding. If people have an intracerebral hemorrhage and they have atrial fibrillation, people who resume oral anticoagulant therapy do better than those who do not, be that hemorrhage lobar or non-lobar. And it's true that we now realize that even people who have an intracerebral hemorrhage have an increased risk of ischemic stroke in the aftermath. And so these patients do better. Of course, you could risk stratify by doing an MRI to see whether there was presence of microhemorrhages on the gradient 2 echo. And that might help make a decision one way or the other, or firm up your belief as to what you're doing is appropriate. And again, of course, I suppose the question about whether nothing should have been administered, but we look at an atrial appendage occluder, I suppose there's 2 things to say. Of course, if you use an atrial appendage occluder, you're going to have less hemorrhage. But whether it will truly prevent less ischemic stroke rather than effective anticoagulation, that's not quite so clear-cut. And of course, not all thrombi form in the atrial appendage or even embolized from there in atrial fibrillation. And of course, you would also, John, have to use dual antiplatelets for a period after putting in the atrial appendage occluder, which in itself would be the risk in intracerebral hemorrhage. So I think I would have waited for a month to 3 months and then have considered oral anticoagulation. And I suppose when we were writing the practical guide to oral anticoagulation, atrial fibrillation with NOACs, we kind of pointed out some of the things that might make you consider not introducing oral anticoagulation, because we do want patients to be safe. But basically, if you decided that there was such factors such as severe intracranial bleed, or they had multiple microbleeds on their MRI, and that they had uncontrolled hypertension, for example, then you might be inclined maybe to say, well, I'm not going to initiate an oral anticoagulant here, and then it might be appropriate to consider the left atrial appendage occluder, I think. But I think most of us would now agree that we would restart oral anticoagulation. And I think when we were writing the next issue of these guidelines, we'll reduce the number of microbleeds that we would consider significant, certainly.
And you would prefer a NOAC because of the renal function with a creatinine clearance of 38?
Well, I think in terms of the overall risk of intracranial bleeding in this situation in particular, I would be definitely going down the route of a NOAC, definitely. And I think in terms of the renal function, I would probably be steering away from the direct thrombin inhibitor, certainly, maybe towards more 10A inhibitor and renally reducing in that regard. I suppose the other issue with regard to this woman, she is 92. She broke her hip when she was 87 or thereabouts, so she's quite older. And you would consider her fall in her fractures maybe suggestive of frailty or reduced resilience, which is the term I prefer myself. But when we consider actually who are our atrial fibrillation patients, I know we're all biased by the patients we see every day. And I'm sure you might have patients when you consider AFib who are 50 and 55. But the majority, of course, of patients with atrial fibrillation are older. And epidemiological studies show very clearly that it's really after 75 that prevalence really shoots up. It is an age-related condition, of course, atrial fibrillation. And this population also have changing weight. So although most older people maintain stability, about 20% of older people will lose between 5 and 10% of their initial weight over 3 years. And you've got to watch that, obviously, when it comes to dosing and renal function as well. We also know, of course, and going back to the 1950s, we've known for a long, long time that age itself predicts a decline in renal function. So we must monitor renal function in older people. And although preventative medicine with regard to hypertension might have gone better, renal replacement therapies also got better. And overall medicine has resulted in greater longevity, which is a great success story. But it does mean that the rise in incidence of chronic kidney disease is very much a disease of our time as well. And of course also diabetes, very much an age-related condition as well. And as you can see, older people are much more likely to become diabetic.
So you're pointing out that old people have lots of
multiple
comorbidities. And that is going to represent a bit of a challenge in terms of how you prescribe drugs and so on.
I think so. And it also, of course, a lot of these risk factors are also risk factors for both hemorrhage and clotting. And that's one of the great contradictions in aging in terms of that risk of bleeding versus risk of clotting. And what would you do in a situation like this? And of course, going back to the falls issue, and this is from our own longitudinal study, the TILDA study in Ireland, you can see that between the ages 65 and 75, about 1 in 5 people are falling, which is a lot. And a proportion, about a quarter of those are non-accidental falls as well. And of course, above the 75 is about 8% will experience a non-accidental fall. And these are the type of falls you worry about because you may not be able to affect the environment. So falls is a factor of aging as well, and we need to be bear in mind. And this brings me to this concept which we tried to introduce into the last guide, the concept of a phenotype of frailty. Having all these medical comorbidities, yes, but what does your patient look like? Because a patient can be vulnerable or moderately frail, and that group, a small stroke will make all the difference. It can mean the difference between going home again and residential care or death. And I'm not advocating, and I don't think anyone would advocate that people who are very severely frail should be on an oral anticoagulant if there's no benefit, in the same way they shouldn't be on a statin. But certainly I would not use just the concept of frailty or reduced resilience in itself as a reason for not anticoagulating people who are at risk of stroke. And I think this was nicely summed up by Kirchhoff, and he looked at essentially, if you like, encapsulating frailty into these 4 main areas: that older patients with AF, a lot of chronic kidney disease. You've got that contradiction between high bleeding risk and high stroke risk from thromboembolic disease. Polypharmacy, which is a feature of most older patients, and this history and tendency to fall, which I've alluded to. And so I suppose in the 50s, maybe more your patients, Martin, mostly, probably needs a lot more cardiology input rather than stroke, geriatric, or neurology. Equally probably needs the same pharmacy. But in the over 70s, we probably need to work together a little bit more in terms of making some of these decisions about patients in their 80s and in their 90s. And again, pharmacy need to be very much involved, and maybe clinical nutrition. I think we need to start defining who should be in our AFib clinics, John. How does that multidisciplinary clinic look like?
I think it's a very important concept, the idea of more integrated care. For these complex patients, they become very complex when they start having lots of different comorbidities, taking lots of different drugs and so on. So the cardiologist needs a bit of help, or if it's a geriatric clinic, the geriatrician needs some help.
Absolutely. Yeah, no, I think you'll always make a better decision, and the patient's treatment will always be better by getting two viewpoints and having heads put together. I think we're all on that page now. And so in considering this lady for stroke prevention and atrial fibrillation now, would you say, listen, well, we cured the big stroke she was going to have, but I wouldn't give her an oral anticoagulant still. She was her frailty. She's had a stroke, she's had an intracerebral hemorrhage, she's had falls, she's polypharmacy, her EGFR is 38 mils per minute. Would we initiate an oral anticoagulant, but monitor renal function and wait carefully, given her age, maybe see her frequently every 3 months? Should we reduce the risk of bleeding, particularly here with aggressive control of her blood pressure? Should we be looking at the SPRINT trial, for example, and getting down to 120/80 in this lady? And should we review and reduce the risk of falls where we can by having this comprehensive multidisciplinary geriatric assessment with MDT input?
Well, those are 4 really very interesting questions. I'm sure more than one might be right. But over to you, your time to vote and give us your answers. Go ahead and vote now. Well, interestingly, the voters seem pretty clear. Option 2 is the one they strongly favour, less support for the others.
Well, that's true. I think the first one, I don't think any of us, this woman was independent, 92 or 97 or 102. She was living independently at home. And so she was at very high risk of Child-2 vascular 6. She was deserving of her thought processes here in terms of anticoagulating and not to be dismissed. I think certainly in terms of initiating oral anticoagulant and monitoring renal function, it's very reasonable. I think we suggested in the guideline creatinine clearance divided by 10 is a reasonable interval to follow people up. I certainly would see her within maybe 3 to 4 weeks after starting the oral anticoagulant. Reduce the risk of bleeding with aggressive blood pressure control, SPRINT trial? Maybe, but probably too tight in this age group. She did have a fall. She does have renal impairment. You could worsen that potentially. I think hopefully we're all on the same page that it's always a good idea that we look into disciplinary and have a comprehensive geriatric assessment of such patients, because a lot of falls can be prevented by improving proximal muscle strength and remediation steps and just having a medication review in general of older people. We have to remember, as you get older, that risk of stroke exponentially rises in atrial fibrillation, probably the most powerful predictor after a previous stroke and having a stroke in atrial fibrillation. And of course, one of the early studies looking at this, although numbers were small, but I put it up here specifically because it was almost a gerontological view of this. What you find in frailer people is that they're less likely to be anticoagulated. But if you look at severe hemorrhage and cardioembolic stroke, sure, there's an increase in hemorrhages in frailer people compared to non-frailer people, but that's not significant compared to the increase in risk of thromboembolic stroke. And I think it's important to remember that people might bleed, but they're much more likely to have a thromboembolic stroke. I suppose when it comes back to looking at the newer agents, we can draw comfort, John, from very large meta-analysis of huge numbers of patients, that the age effect in terms of efficacy, these drugs are as effective in the over 75s as they are in the under 75s. There isn't an age interaction, perhaps with the exception of high-dose direct thrombin inhibitor. And similarly, when it comes to safety profile, older people are more likely to bleed, but the same strong signal that they're safer than maybe our traditional VK, and particularly in terms of intracranial hemorrhage. So we can draw confidence here. I suppose if you look at real-life registries, and you may want to comment yourself, John, having a lot of experience in real-life registries, but one of the things I take from this is that certainly as you get older, you're more likely to bleed, and you're more likely to have a thromboembolic event. But you're much more likely to have a thromboembolic event than you are to bleed as you get older. It's also interesting to note that if you look at the bleeding in older people, whether they're on an oral anticoagulant or not, there's not that much difference. And aging in itself drives bleeding risk in its own right, but it seems to drive thromboembolic events slightly more, at least in the PREFER AF registry. I think falls have been traditionally, and I would reflect within my own specialty on this, we've probably not anticoagulated people in the past because we thought they were too high risk of falls. Not all falls are the same, of course, but you can see here in this one review that people who were at risk of falls, less than half compared to people who were not at risk of falls, got anticoagulation. And of course, I suppose we have some modern evidence, both with the sponsor's drug and with this drug, and this is Jan Steffel's paper looking at people at risk of falls. And what you find here, which is very reassuring again, is this huge safety issue when it comes to intracranial hemorrhage. Because I think most geriatricians, like most doctors, were worried someone falls, they're going to have an intracranial bleed. Sure, fallers, people who are fallers, it may be a risk marker for frailty, are more likely to bleed, but the intracranial bleeding is much lower with the newer agents than it is with the VK antagonists. So I would draw some comfort from that. So in summary, from my perspective, I suppose as a humble geriatrician, but from my perspective, age is not a barrier to stroke prevention and atrial fibrillation, and indeed many older people have most to lose actually. Many aspects of frailty are a risk for bleeding, but also, and probably more prevalent, ischemic stroke. Of course, we need to consider oral anticoagulation safely. I don't think any of us are suggesting we irresponsibly throw these drugs at people who are older and frailer. And older people do need more monitoring. And I think we need to be more interdisciplinary together in all our hospitals and running our AFib clinics.
Well, thanks very much for that talk,
Thank
Ronan,
you.
particularly for your summary. I think people should just look at that for a moment and remember those 4 very important points. But next we're going to move to Martin Hemmel, who's going to give us a second case to consider. Over to you, Martin.
Thank you, John. These are my disclosures. And what I'm going to do is a somewhat younger patient, as we spoke about before, but interestingly, a 72 years old patient with several comorbidities. Diagnosed with hypertension, diabetes, paroxysmal atrial fibrillation with minor symptoms, and by that time a CHEST-VESC score of 3 points. And in 2016, echo showed a moderate aortic valve stenosis with a mean gradient of 36 and an aortic valve area of 1.2 square centimeters. Renal function at that time, normal hemoglobin and thyroid function. And when we look at the drugs, the medications coming in the next slide, but in 2018, the patient came back with recurrent iron deficiency anemia using apixaban 5 milligrams 2 times a day. Renal function at that time was still normal. So here you see that 1, 2, 3, 4, 5, 6, 7, 8 drugs, 72 years old. And this patient is getting a little bit angry because he says, I was on aspirin, there was never a problem, and then I was put on apixaban in 2016, and now I have recurrently the anemia problem. So he asks us, it's a recent case in our hospital, to go back to aspirin. And the question to the audience is now, what would you do or advise this patient? Do you say, I go for number 1, I stop apixaban and switch to aspirin? Or 2, no, we have to close the appendage and maybe also do a PVI, and then we can safely switch to aspirin? Or do you see option 3, just reduce the dose of apixaban and maybe that will solve the problem? Option 4, switch to a different NOAC or a vitamin K antagonist. Or option 5, first further analysis by an internal doctor.
Martin, that's a very interesting list of options. So we must find out what everyone thinks. Please vote now and tell us what you would do. Well, the vote is very interesting to me. I never really expected that this would be the answer. But 60% of people opt for number 5.
Okay, very good, I would say. Because you first want to know what's happening in this patient. And so the analysis was done by the internist and gastroenterologist, and gastroscopy and colonoscopy didn't really give answers to our question, although there was some atrophic gastritis, but not what you sometimes see in case of aortic stenosis, angiodysplasia, but we didn't see that at that moment. But interestingly, there was also done an echocardiography again, and then, and this is 2 years later, you see that it's had become a severe aortic stenosis with a peak gradient of 71 and aortic valve area below 1. So, and also with the left atrium enlargement, we have another problem, I guess, than we saw 2 years ago. So then the next question comes, what would you advise this patient now? Option 1, you go for a TAVR and switch to aspirin. Maybe that's a good option. Or no, that's not enough. We have also to close the left atrial appendage to make it safer, less stroke risk. And you can discuss whether or not you do a PVI also and then switch to aspirin. Or you just say we go for the aortic valve replacement and then we can safely continue apixaban, option 3. Or you go for option 4, we go for mechanical aortic valve implantation and then you can discuss whether or not you do a MACE surgery or epicardial radiofrequency MACE, and then switch to warfarin or vitamin K antagonist. Or option 5, you go for biological aortic valve implantation, and again with or without rhythm surgery, and then just safely continue apixaban.
Again, that's a very, very interesting list of options, combining considerations of the aortic valve and whether that should be replaced, and also anticoagulant issues. The vote's already in, and it's interesting that 48%, nearly half, thought option 3 was the best approach, and over a quarter thought that option 5, the biological aortic valve implantation with or without MACE surgery and continuing apixaban, was a good way forward. What did you do, or what would you do?
Interesting. We went also for an aortic valve replacement, but I put this question like this because you have to see that patient, and the patient was really reluctant to continue the NOAC because he associated the bleeding really with the NOAC. And that's why I also wrote the answers towards the possibility to get him the aspirin back, but I think we have, and we did, you have to talk with the patient and just say that there are other problems that cause the bleeding, and it's not particularly the apixaban. And I will show you why we think, and up till now we also see that probably was the problem. And that's about acquired von Willebrand syndrome in aortic stenosis. This is a paper out from 2003 from the New England Journal of Medicine, and the group of Vincentelli looked up 50 patients with moderate to severe aortic valve stenosis, and they did also laboratory tests, and what appeared to be the problem, that the multimeres, by the shear stress of the aortic valve stenosis, caused platelet binding loss, and that's known as type 2A von Willebrand factor deficiency. So platelet activation was diminished by the destruction, the damaging of those multimeres. And this is not something what's happening once in a while. They found that it was in 92% of those 50 patients, there were problems with platelet activation. And the severity of this problem was in a linear relation with the severity of the aortic valve stenosis. So the more severe the stenosis, the more platelet activation problems happened. 42 of these 50 patients were operated, received a new valve, and very interestingly, they measured with laboratory tests the platelet activation before replacement at day 1, day 7, and after 6 months. And what you saw was, and that's at the right side of this slide, that before replacement, what I said was in 92% of patients, there was a problem with platelet activation, and that normalized within 24 hours after surgery. So that's very interesting. Within 24 hours, it just normalized. And okay, you see that after 6 months, there were some patients who had the problem again. And these were the patients who had mismatch or other surgery-related problems.
Patients who still have an aortic gradient,
Yeah.
aortic valve gradient.
Yeah. And on the left side, I show you the bleeding problems which happened. And these were patients without anticoagulation. But in 21% of patients in the half year before surgery, bleeding problems happened. And I think in the EHRA, and that's why I'm bringing this case with elderly people, we're going to see a lot of patients with moderate to severe aortic valve stenosis, sometimes discussion with patient and family whether or not to do surgery. But I think we have here a modifiable risk factor of bleeding. And that's something you have to keep in mind when you are discussing whether or not to replace an aortic valve in the elderly patients, especially when recurrent anemia and bleeding occurs. And this slide I show you to tell you what you should not do, and that's just reduce the dose. This is an example from a real-world study of the group of Nielsen, and what they did was taking the patients from a cohort, and these are only the patients who were undertreated, underdosed for their factors that should be lowering the dose. They didn't have those factors. So these patients all should have the full dose of NOAC, but they received the reduced dose. And what you see then is when you look at the cumulative incidence of stroke and other embolus, that the NOACs are above the warfarin-treated patients. So underdosing leads to a higher stroke risk. And
Treatment failure.
Absolutely treatment failure, yeah. And apixaban is a good NOAC, no discussion about it. But when you underdose apixaban in patients, you go to 50% of the dose they should have got. And then that's maybe the explanation, but it's not statistically significant, but maybe that's one of the reasons why apixaban in this cohort has a worse outcome.
Why do we do this? Are doctors bad prescribers, or is it just fear of bleeding?
We see it a lot.
What makes
We
us
also
do this?
I think it's a particular problem because the dose reduction strategy with the different NOACs, the strategy is different. And therefore, physicians get a little confused about it. And for example, if you've just got renal impairment, you dose reduce with rivaroxaban, but you don't dose reduce with apixaban. You have to have two of the three factors, a weight less than 60 kg, age over 80, or impaired renal
Function, yeah.
So I think it can be very confusing, as well as the natural tendency of doctors not to give what they think is too much anticoagulant.
Yeah. I think really the fear of bleeding, causing bleeding by the patient is also a factor that there's a lot of underdosing. We saw it at the late-breaking clinical trial on the ESC, a big French cohort, the same problem, underdosing. And with a short follow-up, you have short wins, quick wins on bleeding. So it seems not really a problem. But when you look in the long term, you will see that these things will happen, that there are more strokes.
Physicians are always struck by this primum non nocere principle, but of course this blows it out of the water, doesn't it?
Yeah.
This is actually doing harm by
Yeah,
thinking
but their
about
physicians often don't realise the harm they're doing by under-prescribing the dose.
Then the other question or problem, when there is bleeding, is there a time or a moment that you say, okay, now it's time just to skip the anticoagulation because this is not ethical again, or a patient really has problems with continuous anemia problems? This is one of the reviews that are there. This recent review we wrote with a group from the Netherlands, and I just show you this especially for the monitoring plan. We can discuss about all the things, these are also in the guidelines, what you have to look up when you want to minimize the risk of bleeding. But I think especially in the elderly, when patients go back from the hospital to the general practitioner, you have to make a monitoring plan. assess hemoglobin levels and renal function at least yearly, sometimes 3 to 4 times a year, probably, and stimulate and monitor therapy adherence. I think that's also still important in the NOAC era, and actively ask for bleeding, minor bleeding, and what the patient thinks of that, and maybe gets more feared. And it's especially with minor bleeds, when a patient doesn't go to the doctor, that it makes decisions itself. We always speak about the major bleedings in the big trials, but I think minor bleedings we may not forget.
But the patient is often very aware of the minor bleeds, the nosebleeds and so on and so forth.
Absolutely.
Yeah.
And the problem is solved very quickly when you stop the anticoagulation.
Yeah.
This is what we talked about in your talk, Ronan, that when you look up for different kind of bleeds, it's also for GE bleeds, it's most of the time better to restart, first solve the problem when there is something in the gut which you can solve and the bleeding risk is lower. You have to do it and restart afterwards. But this is to show that in most cases, when you look carefully for the risk for the cause of bleeding, you can restart safely. And when you do not restart, patients do worse. This one is also what we a little bit discussed about already, but there's a beautiful graph from the sub-analysis of the ENGAGE trial. These are only warfarin-treated patients, and when you see on the left side, Ronan already stated and discussed that by increasing age, the red bar is are the eldest people above 75 years of age, you see the most bleeding problems. You still see more ischemic stroke, whether or not you anticoagulate. But I want to show you the right side of the graph, and I think this is for the coming 1-2 decades really a problem. These are warfarin-treated patients, and still, that's also logical. You see stroke, I said it before, but what's happening is that bleeding really has an uptake exponentially, more bleeding problems in the elderly. And this will lead to discussions every now and then, whether or not to restart, to give lower doses, what to do with anticoagulation. Because it can be very harmful when, for example, moderate bleeding comes a few to many times a year. That is also disabling, just like a stroke. Then another marker for, we also discussed it a little bit, another marker for potentially higher bleeding risk is polypharmacy. And this is a sub-analysis of the Aristotle when where you see that there is a clear association between the number of drugs and the risk of major bleeding. And there is not a big difference between warfarin and apixaban. In both anticoagulant drugs, you see this problem. The right side is somewhat more logical. The more drugs, the more frail patients are, and you also see more all-cause death. But I show you this just to be aware, when you have a patient with polypharmacy, do the monitoring, talk to the patient, because the patient is just at higher risk. And this is a sort of overall overview. We start a lot of anticoagulants in the hospital. We send the patient back to the general practitioner. The patient becomes old and frail. And what you see here is that there's a real life cycle which a patient goes in, and there are a lot of factors that can influence adherence, whether or not to stop anticoagulation for short term or long term, or maybe forever. There's the patient preference, you have the dosing issues with weight, renal function. So we have to be very critical also in the follow-up of a patient who is using anticoagulation. And that's also what the guidelines say. We have to be critical on modifiable bleeding risk factors, and we know the classical risk factors, but I also show you this to little bit discuss about the biomarker-based bleeding risk factors, because we know that the clinical bleeding risk factors, for example, has bled, can predict bleeding moderately to good, but in patients below 70 to 80 years of age and above, these risk scores are not validated. And what we saw, for example, in Aristotle, there were 82 biomarkers tested, and GDF-15 was the best predictor of bleeding. And it's also in the ABC bleeding risk score, and some countries are working now to make that risk score even better. And I think this is one of the targets for the future, to get better bleeding prediction.
Although we've got to be very careful that predicting bleeding does not stop people being properly anticoagulated.
Yeah.
You should do something about the bleeding risk if you can.
Yeah.
But it shouldn't put you off unless it's really a very big risk of bleeding.
I fully agree, but when you mark that patient as high bleeding risk, you talk to that patient that you can predict there is something maybe going to happen, and when it happens, it's not so anxious for the patient, probably. It's more recognizable, and maybe that also leads to the acceptance of anticoagulation after bleeding, and also adherence issues. So I come to my conclusion of this case. Both bleeding and anemia occur frequently in the elderly and are important causes of morbidity and mortality. Anticoagulation increases the risk of bleeding, but often there is another reason for anemia or bleeding, especially in the elderly. So adequate analysis and treatment of possible underlying causes of bleeding is important in case of unexplained anemia, and helps to prevent underdosing and underprescription of OSA in atrial fibrillation.
So, well, thank you very, very much, Martin. So we've had 2 talks now, and it's time for some questions. I'm pleased to say we've got lots of questions. And the first impression I have is that there are lots specifically about one point, and it's directed straight at you, Ronan.
Oh, no.
It ranges from, is there any age limit for anticoagulation? It goes through specific questions like 118-year-old, would you really anticoagulate a patient like that? And then it goes on to say, I'm scared stiff of anticoagulating patients who are very old.
I think there's 2 points to that. I think in geriatric medicine, initially when it started out with an age-defined criteria, that was a mistake. It was an arbitrary line of 65. I think it was originally based on Bismarck's prediction of pensionable age, as far as I remember, although I think he suggested 67. In any case, no one got a pension back then, so it was a good suggestion economically. But in reality, people's phenotypes bear little resemblance overall to their actual age at times. And that's the important issue. And I suppose, John, as you mentioned, you talked about people, centenarians. I mean, our children will be healthy centenarians in all likelihood. So again, the dangers of drawing the line in the sand. I have patients who are in their early 60s who have very bad phenotypes, who I'm not sure that anticoagulation would benefit them in atrial fibrillation, who are already incapacitated through bad lifestyle choices or bad luck. I have many people in their 90s who are living completely independently with minimal comorbidities, although that is a rarity, I accept. But again, those patients, a small stroke even, could be a disaster, because there probably is an underlying reduction in resilience there. So even a small cerebrovascular event could provoke, if you like, a cascade, which would result in them losing their independence at home. So I really would steer away from age as an issue.
But you have pointed out to me, Ronan, you've told me that there's practically no randomized control trial data in patients over 85.
Correct. And I would love someone to step forward and let's do it, because we have enough patients in our 90s to at least do it. But these things are, and I would be in favour of that. I would go back and I would talk about the thrombolysis trials, both cardiac and in stroke. And initially the SPC for thrombolytics again suggested that patients who were over the age of 75, or I think in TPA over the age of 80, it wasn't in the license. But we subsequently found out that older patients benefited just as much from those interventions as younger people. And again, I go back to the point, you could argue as well with randomized controlled trial whether the number or your date of birth is actually an important variable. It is, of course, but whether it's an independent, purely predictive variable in which you make all future decisions, I'm not sure. I'd love to do a trial in the 90s, John, if someone's out there. Please approach me.
Maybe you have to enrich the endpoints, for example, with reduction of progression of dementia, for example.
Correct. Correct.
And it's not only about stroke or mortality, but I think when you start early enough, but it's hypothesis generating, but also there are some signals that it also helps to prevent vascular dementia.
No, I think there's increasingly strong signals, and again we need to go back. But I go back and let me correct myself. Don't approach me about a trial in the 90s because I actually don't have equipoise in my head, John.
Okay, well, that's an important concept because no good trying to do trials if people don't have real equipoise. But both of you mentioned polypharmacy, and there are several questions on that, particularly because one of the slides compared warfarin, a vitamin K antagonist, and NOACs. And they both seem to have as much problem from polypharmacy as the others did in terms of increased bleeding and so on. So what's the story there? Because the NOACs were developed with having less drug-drug interactions in mind. So where is this? What is this telling us?
Yeah. I think we have to gather more knowledge about the elderly using, for example, NOACs, because glycoprotein expression seems to be different in elderly. Maybe you can comment on that. There's an Italian group who showed that glycoprotein expression is different in elderly and can be very heterogeneously, and that's a factor we didn't see or didn't investigate in the phase 3 trials with a mean age of 71 years of age.
Yeah, I think there's 2 points. I think polypharmacy in itself is a risk marker. It belies multiple comorbidities. And of course, some of the drugs themselves directly cause bleeding. Non-steroidals would be the most famous example probably in this setting. And going back to what Martin was alluding to, certainly we know that the P-glycoprotein system, the expression decreases in the gut, in the blood-brain barrier, and even in leukocytes in older people. And not only that, but the expression of the P-glycoprotein in the gut changes as we get older, so it seems to decrease faster, more proximally than it does distally. And of course, depending on where the drug is absorbed, that may have a direct influence. And again, there's a bit more work to be done in this, but certainly we make assumptions at the moment, I think, in terms of what happens in every cohort of age with regard to the absorption of these drugs. But I think the major driver in polypharmacy as a risk factor for bleeding is because it belies all the comorbidities that a person might have. But the one thing I would say, John, is that, and this is true of my clinic, and I'm sure it's true of your clinic, and this is the role really of pharmacy in our clinics. And again, we need to be critically reviewing, why is the patient leaving my clinic with a bag of drugs? And that is true in many cases.
Oh yes, they come to my clinic with a plastic bag absolutely full of their prescriptions. I'm not sure whether they're taking them or not. It's always a big difficulty, I think.
It is.
More questions though. Questions about an old patient, Martin, who had an attack of atrial fibrillation some years ago. It was terminated spontaneously. At that time, he didn't have any risk factors for starting an anticoagulant, but now he's 5 years older. Yeah. He's developed some hypertension. He now has risk factors, but his atrial fibrillation was 5 years ago. When they do Holter monitoring, it just has a lot of APCs. Yeah. What would you do?
Very interesting. I would talk to the patient that because of his history or her history, there is an indication to start anticoagulation, because we just know that atrial fibrillation in the past is a marker for a higher stroke risk. And when you have also the risk factors, I think I would talk to this patient and say, you are safer off with anticoagulation. And the same accounts for secondary AF. It's still a discussion, but we now have seen some cohorts where it's clearly shown that when you treat them chronically with anticoagulation, they are better off than just say, okay, this was because of an infection and the problem is solved. I think, again, it's a marker of vulnerability, that these patients are vulnerable for atrial fibrillation, but also the consequences.
Would you
it brings
apply
to the
that
bone.
to a patient, say, who had some atrial fibrillation post-operatively, or a patient who just had a bit of AF following a pneumonia or during pneumonia, but now it's some years down the line, hasn't had any symptomatic recurrence at least. Holter monitor doesn't show much, but now plenty of risk factors for thrombosis if atrial fibrillation develops.
Yeah. The guidelines at the moment state monitor these patients very carefully, because when you find again atrial fibrillation, then you have a clear indication. And I think there's still a difference between a CABG patient who has 1 day post-operatively just a short episode of atrial fibrillation and an 88-year-old woman who has 1 week of atrial fibrillation at a pneumonia. I think that last patient is far more at risk than the somewhat younger patients with a CABG. And maybe that's also the link to device-detected atrial fibrillation. Is also something we discuss a lot about. That's also an early recognition of higher stroke risk in the future, but it's still less than clinical atrial fibrillation. And we also saw that in the Copenhagen Holter study. A lot of PACs at 55 years of age is a predictor of atrial fibrillation 10, 15 years later. So monitor them carefully, and in the meanwhile, we have to gather a lot of data to be sure in the future.
Yeah. Ronan, another tranche of questions, not one but several, all of which say it's all very well giving an anticoagulant to somebody with moderate renal impairment, because you can compensate for that by perhaps reducing the dose where appropriate. But what about patients who have CKD 4 or 5? And also, several people ask about hemodialysis. Are NOACs the drugs to go with? Should you use an anticoagulant at all? What's the way forward there?
The first point, actually, just want to speak about age, basically. The more worrying problem with Martin's first patient, by the way, who was, let's say, 62. Let's say his atrial fibrillation hadn't gone, John, and it was persistent, but he's 62. What do you do? He's no other risk factor. Because there's that arbitrary line about age appearing again. I even saw a letter once. The patient will reach 65 in 2 years' time. He should come back then, at which stage he will be eligible for an anticoagulant, which made me think, there's a lot we don't know yet, and we do need to tease it out. Going back to the renal failure, it's an interesting issue. Certainly, there's two things. We have traditionally anticoagulated people with warfarin who had end-stage renal disease, even though the existing evidence suggested that at best warfarin was neutral and actually was harming a lot of these patients. We also know that warfarin accelerates renal decline, for example, in comparison to drugs like dabigatran, and we knew it anyway because of the vascular calcification problem associated with warfarin. And then we come into hemodialysis issue. I suppose what we are now seeing is that, many of the NOACs have a license down to 15 mils per minute at a reduced dose, obviously. And we're beginning to see the first move to using apixaban, and the FDA have approved it in people who are starting hemodialysis. Now, I myself am not convinced that we have enough evidence there. Nor am I convinced on the dose, by the way, but
I think all the FDA has done so far is give some recommended doses.
Yes, yeah.
And they've done that for rivaroxaban as well. But as you say, there's very little, there's no
evidence.
Clinical trial data.
No.
There is some observational data, but no really good comparative data because it's not randomized.
And pharmacokinetic data in a small group of patients, I might add as well. But I suppose we also have to acknowledge as doctors, this is one of the known unknowns. We used to do this with warfarin in the absence of strong evidence as well. So again, at least doctors would think, well, I want to prevent a stroke. I think the question we need to answer here is that in renal failure patients, how do we best prevent that risk of stroke now? I would be inclined to believe that in the same way that the NOACs are better than warfarin in patients without renal failure or with moderate renal failure, that they're probably as good, if not better, in patients with severe renal failure as well. But that is not based on firm evidence. That's my feeling.
And I think there's lots of different opinions around the world about how we deal with that. But as you say, I think we'll get more information eventually. Martin, there's a question here pointing out that you brought up the issue of a patient with valvular heart disease, and he or she, I can't remember, was taking a NOAC, a apixaban, valvular heart disease and a apixaban. Mm-hmm. Now, the questioner wants to know why that choice.
Yeah, now, it's important that there's a lot of discussion and also misthinking about what's valvular heart disease and non-valvular heart disease. And in the guidelines from 2 or 3 decades ago, non-valvular heart disease is every patient also with insufficiency or stenosis of valves. And valvular heart disease is only the group with mechanical heart valves or a moderate to severe mitral valve stenosis. So that makes it difficult. All the patients with moderate to severe valve disease, except for the mitral valve stenosis, these are all non-valvular atrial fibrillation. So what I always tell to my general practitioners when they have a patient with de novo atrial fibrillation, just start anticoagulation, start a NOAC, because this patient doesn't have valvular AF, because when that patient has a mechanical valve, there's already warfarin in this patient. And when a mitral valve stenosis appears on echo later on, then the patient is better off on the long term with vitamin K antagonist, but maybe in the short term even
and we're waiting
better
for
off with
clinical
NOAC
trials in that area as well. We don't really have the information, but everyone's concerned that the added element of the chronic inflammation in rheumatic heart disease may worsen the risk of thrombosis, and can NOACs deal with that? Probably they can, but we have to wait and see. Currently, the guidelines say that it's all right to use NOACs in patients with all sorts of valvular heart disease, just not metallic heart valves and not moderate to severe rheumatic mitral stenosis. One last question for you, Ronan. Several people want to know, if you've got a very elderly patient and you're going to anticoagulate them and you've chosen a NOAC or DOAC, which one?
Ooh, that's a tricky question.
Is there a good reason to choose between them for elderly patients?
I suppose there's 2 answers. I think all the trials, first of all, only had a small proportion of people over the age of 85. I think less than 5% of the cohort. So that's the first thing to say. We don't have robust evidence. But then again, like I said, I don't think age is the most important factor. It's the phenotype of the patient and the other comorbidities. The short answer is that older people are more likely to bleed, and the particular signal you get is with GI bleeding in the NOAC trials. So I would pick the 1 or 2 agents that have got the lowest instance of GI bleeding, and I think there's a signal there. I'm not sitting on the fence about this, but I think there's reasonable evidence to suggest that kind of the rate of GI bleeding in more advanced age, you're probably less likely to get it with a apixaban or with a doxaban, I think.
Well, thank you very much, both of you. We're now approaching the end of the webinar, and I'd like to close the session by summarizing the key messages for your daily practice. Professor Collins emphasized that old age, indeed very old age, is not a reason for omitting oral anticoagulant therapy. However, elderly patients have multiple comorbidities and are subject to polypharmacy, which together may complicate the management of AF patients at risk of stroke. Anticoagulation, preferably with NOACs, is usually still a major advantage even in the elderly population, although bleeding will be more common. Sometimes dose reductions are needed, but patients should be carefully assessed, carefully treated, doing everything possible to reduce the bleeding risk. Professor Hemmels reinforced all of these points and introduced to us the fascinating Heidi's syndrome of mucosal bleeding associated with aortic stenosis. Remember, unwanted bleeding in elderly patients can sometimes be greatly reduced by appropriate relief of aortic stenosis. So, thank you to Professor Collins and to Professor Hemmels for their presentations. Remember, this program is supported by the Bristol Myers Squibb and Pfizer Alliance in the form of an educational grant. And remember also that you will be able to watch this webinar on demand on the ESC website. So last of all, thank you from me.